Good morning, everyone, and welcome to this session. Feel free to use the chat box to introduce yourself. I think just as Neil mentioned, we're recording this session and it will be available on the Health Creation Alliance's YouTube page, hopefully from the middle of November. We also intend to have a short write-up of the session, and that will be made widely available. So please feel free to use the chat box, introduce yourself along the sessions, share your views, your observations, any links to useful resources. And I think there will be opportunities for you to, ask questions or get response to questions that have been put in the chat box. So this session is one of 6 online, and next week there will be one in-person event taking place as part of the Health Creation Coming of Age series. We hope during this next 2 hours you enjoy the session and you can join in the other sessions. We will also encourage you to join the Health Creation Alliance for free and play your part in spreading and advancing health creation. At the end of the event, there will be links shared for evaluation, and we will be absolutely delighted for you to complete that because that's very important. We want to say massive thanks to all our partners and sponsors who have been supporting these events. So the National Health Executive, the Public Sector Executive, HLM Architects, NHS Property Services, Novartis, PPL, Solis, South Central West, the Health Creation Alliance's patron, Lord Victor Adibowale, and then Lord Nigel Cripps. So the Health Creation Alliance is delighted to be working with, our partners and sponsors, bringing these sessions together. And without them, it wouldn't be possible to bring you such stimulating, timely, and information series of events. So what and why? What is coming of age and what is this all about? So over the last 7 years, the Health Creation Alliance has led a national movement for health creation aimed at addressing health inequalities. So for the first 4.5 years, things moved slowly, but in the right direction. But COVID-19 changed everything. COVID is just one of the many disruptive forces we've had in our world today. Yes, it did expose the stark inequalities, but at the same time, making visible some of the hidden aspects of how our communities work, becoming resilient and thriving. It concentrated our minds on how inequality leads to poor health outcomes, and also how health inequalities can be addressed by creating conditions for communities to become stronger through connections. So in the last 2.5 years, things have been very different, and health creation is experiencing what might be described as coming of age. It's undergoing a metamorphosis, but there's a lot more maturing still to do, and health creation must become business as usual across all our systems alongside our efforts to treat illness and prevent ill health. As we move into a new phase where much broader partnership and collaboration become possible, our collective mission must be to build back together, including what those communities who experience the poorest health outcomes. We must increase our efforts to make the necessary changes happen in a timely manner. We, as part of this series, also issue calls to action for all ICSs. And the Health Creation Coming of Age call to action is for all integrated care systems to recognize health creation as equally important in addressing health inequalities as the treatment of illness and the prevention of ill health, and to adopt and embed health creation as a way of working, making it business as usual across the whole system. As we go along, we will identify further calls to actions. So I hope you've introduced yourself, and we're going to crack on. And the first presentation will be from Bola Akinwale, who is Deputy Director for Policy and Sector Insights in NHS England Healthcare Inequalities Improvement Team. She will be touching on the Core20plus5 program, what it is, how it is progressing, and what is expected to achieve. So Dr. Bola Akinwale, thanks for your time, and over to you.
Thank you very much, Charles. So I'll be speaking to some slides. So if I can have my slides up on the screen, I'll make a start. So I joined the National Healthcare Inequalities team about 6 months ago. I'm a policy professional by background, but also have a background in public health. And I came because I was really attracted to this work on a national stage, trying to promulgate the Core20plus5 approach. It's a really powerful approach that gives us all something to coalesce around in our efforts to reduce health inequalities. So I'm going to talk briefly about what it is and why. So next slide, please. So most of you will have seen this diagram, the famous Dahlgren and Whitehead diagram, but it's the best there is, I think, at explaining that there are many drivers of our health and health inequalities, including, our work environments, the living conditions that we live in, the general macroeconomic structure, which we've heard so much about over the last few weeks and months, but importantly also the communities in which we live in, which in turn affect our health behaviours, and they in fact mean that our social circumstances have biological implications and affect our health. So there are many opportunities to intervene. It's a complex issue trying to take action on health inequalities, but there are important ways in which we can intervene through health and care services. And as much as the wider determinants are important, it's about a whole system effort. And so with our work in the Core20plus5 approach, we've been particularly thinking about how do we address inequalities that manifest in the healthcare system. And we know that there's evidence, although are driven by interventions which are taken in the healthcare system. So that's a significant minority of the outcomes that we can affect through healthcare interventions, but equally, it implies that there's more that we need to do besides. Next slide, please. So we looked at the evidence of what are the key conditions which drive inequalities in life expectancy, and it's really clear that the major causes of early death, such as heart disease, cancers and respiratory diseases, are the major contributors to inequalities in life expectancy, and these diseases all follow a social gradient. So in this chart you can see it's a scarf chart produced by the Office for Health Improvement and Disparities, and it shows the contribution of different causes of death to inequalities between the most and least deprived quintiles of areas in England. And so you can see that about a fifth of that difference, for example, is caused by circulatory diseases, so heart diseases basically. So these are really important areas where there's an opportunity for us to make a difference, and are things that we've brought into our Core20plus5 framework as areas of clinical focus. Next slide, please. So the Core20plus5 approach is therefore designed to provide a focused approach for tackling inequalities, focusing on major causes where we can make a difference, but also thinking about the population approach that we want to take. So it offers a delivery approach which is focused, enables us to prioritise efforts and kind of honour the kind of national commitments that there have been to addressing healthcare inequalities. And so we recognise that it's a broad agenda, going back to that Dahlgren and Whitehead chart. It's a broad agenda. It's the stuff that we can't do immediately. It's something that's going to take consistent effort over a number of years, but if we focus down, we can have traction and therefore have a demonstrable impact on reducing healthcare inequalities, because we've identified the areas where we want to make a difference. And that's the premise of the Core20plus5 approach. Next slide, please. So what Core20plus5 does is it sets out our target population and also the key clinical areas for focus picking up on some of those points about the evidence I said about the major contributors to inequalities in life expectancy, but also some of the areas where we know that there's a policy priority and an imperative to reduce inequalities. So our target population is the core 20, our most deprived 20% of areas as defined by the index of multiple deprivation. And the index of multiple deprivation measures areas at lower super output area, so very small areas of geography. It's about communities, and it's about identifying our most deprived communities across the country. The plus is the second element of our population focus, and this is about choosing those groups who experience poorer than average access, experience, or outcomes that are not necessarily covered by that deprivation related definition. So that could include, for example, our groups that experience the most extreme inequalities and social exclusion, inclusion health groups, including people who experience homelessness, vulnerable migrants, sex workers, and so on, where we know there are really important and difficult issues that we need to tackle in ensuring that they're fully included in service delivery. So thinking about our population focus, we've also set out our 5 areas of clinical focus, which include ensuring continuity of midwifery care for women from ethnic minority and most deprived groups, ensuring annual health checks for people experiencing severe mental illness, having a clear focus on COPD by driving up uptake of flu and COVID vaccinations, ensuring early access to cancer diagnosis, and making sure that we do our best on hypertension case finding. And across all of these areas, we've identified that smoking cessation positively impacts across all of the areas. It's one of the major behavioural contributors to inequalities in life expectancy. Next slide, please. So to help make this practical, we've put in place a tailored support offer to kind of spread the Core20plus5 approach. And we've identified specific roles in the system, as well as a collaborative effort to kind of spread quality improvement work across systems. So we have our Core20plus5 connectors, who are people in community, people with lived experience, people who can empower, who can be empowered to help tackle barriers to healthcare in collaboration with services and systems. And so far, we've recruited over 130 connectors, aiming for 400 eventually in the programme. And we'll hear more about the work of the connectors today, so I won't dwell on that role. You'll hear much more about them. The second role is our type of role is our Core20plus5 ambassadors, and so they are people, clinicians, professionals working across the healthcare system who are committed to addressing health inequalities. And so we've recruited over 100 ambassadors so far, and the idea is that this group of ambassadors will form a network. They'll be able to share their expertise, and they will be able to form a bridge between what's happening in frontline services and what's happening in my team in the national policy arena, so that we're really connected to the real issues on the ground. And then the final initiative, which we're really excited about and is just launching, is our Core20plus5 collaborative. And so this is about developing in selected systems a kind of a cohort that can be working through quality improvement methods to really accelerate action on inequalities informed by the Core20plus5 approach. So there will be one collaborative site per region, and what we will be aiming to do is see how we can kind of test innovative approaches to make faster progress, share and spread that learning. So it would be a really good opportunity, working in collaboration with the Institute for Health Improvement, to grow a new core cohort of leaders who are kind of at cutting edge of this kind of improvement methodology for health inequalities. So next slide, please. In addition to those different roles and groups, we also have a number of kind of foundational tools and support that we've put in place. And I think the the key thing I wanted everyone to take away is that, you know, we've got a number of products that we've developed. So we've got a leadership framework that we've developed in collaboration with the NHS Confederation, a dashboard, which is a really helpful tool to help people monitor and take action on inequalities, you know, tied to the Core20plus5 areas that we've set out. But of course, this all relies on the actions of people and professionals in communities. You know, so these tools and assets are important inputs, but actually we need the activity of people out there in communities to make this difference, people who are connected to the real issues that people are facing, not only in terms of their access to the health service, but more broadly in terms of their daily lives and, you know, what shapes their health and the wellness. So next slide, please. And so partnerships between communities and services will be absolutely essential for the success of the Core20plus5 approach. And I thought it would be really helpful for us to reflect on what are the things that communities, services and systems should be investigating together to really make this approach a success. So, for example, there are some issues in relation to identifying our populations and understanding what concerns them. So if you think about the Core20+ population, it's based on the index of multiple deprivation as a kind of definition, and that sets out a number of domains of deprivation, including, for example, in relation to income, in relation to the physical environment. And so, you know, we should ask ourselves, what does that look like in our communities? You know, do we have access to green spaces, transport links? What's the nature of employment? How does that practically affect health and wellness in communities? You know, for example, people mainly do shift work? How does that affect people's interaction with services, if that's the case? And so there are a number of practical issues that I think we can start to unpick if we think about the nature of the lives that people live. About the lives that people are living. Likewise, in plus populations, you know, are most particularly those populations who face the most extreme inequalities. Why do we think that is, and which ones do we want to focus on particularly in our communities? So, for example, I've been having lots of really interesting conversations recently about the nature of rural inequalities and the types of individuals who are particularly affected by inequality in rural areas. You know, conversations about hidden homelessness, about digital exclusion, and how that affects people in rural areas differently from urban areas. I think the next thing is, you know, if we think about the 5 clinical priorities that we set out in the Core20plus5 approach, there's a really important thing to think about, perhaps the health psychology of what some of those clinical conditions mean. So what are the beliefs, the illness perceptions that influence people's interaction with services? How does that vary across different communities? So, you know, we can think about communities of place, interests of culture. What degree do those different community perspectives affect the way in which people will interact, say, with hypertension case finding, with blood pressure checks? But also, I think it's really important to think about what are the wider or upstream factors that we could be addressing in partnership. So I've picked one obvious example in the slide, which is around the implications of housing quality. We know that the quality of housing has major ramifications for our health, both mental health, respiratory health, for example. What is it that might be done in partnership with across systems that helps to address some of those issues that might have implications for the issues that we're trying to tackle in the Core20plus5 approach, but also health inequalities more broadly? So I'll leave it there with some questions and food for thought, and really look forward to the conversation later on.
Thank you very much, Bola, for that insightful presentation. We're going to move straight on. Please feel free. use your chat box. If you've just joined, you can introduce yourself in the chat box, and there will be time at the end for us to, discuss. But feel free to use the chat box if you have any questions or observations. We're going to move straight on, and I'm going to hand over to Meron Simpson, who's the Chief Executive for the Health Creation Alliance. So she's going to be touching on health creation and Core20plus5, building successful relationship dynamics. And Meron will also offer a summary of what the health creation is, focusing on and the dynamics of the relationships required. Over to you, Meron.
Thank you, Charles. And thank you, Bola. And we do know we have had reports that the Core20plus5 framework approach and program is helping to bring that new focus on some of those communities and cohorts that have been overlooked in the past and that have the poorest health outcomes. So that it is helping to forge those connections. So thank you for the work that you're doing. I'm just going to do a quick introduction to the Health Creation Alliance and health creation, and then move quickly on to why the dynamics of relationships, particularly between the community and the front line, are so critical. The slide that's just going to come up is the next one, which is that in case you haven't come across us very much before, the Health Creation Alliance is the only or the leading national cross-sector group, a movement. We are addressing health inequalities through health creation, and we're a movement of professionals from many sectors and community leaders and people with lived experience, all working together to address health inequalities through health creation. And our mission is to increase the number of years people live in good health in every community. And our ambition and the call to action that we're starting with for these sessions is to ensure that health creation sits alongside treating illness and preventing illness, and that it becomes business as usual across all systems. So what is health creation? And well, health creation is a process, and it's the process through which individuals and communities gain a sense of purpose, hope, mastery, and control over their lives and environments. And if you could just pop the slide back. Thanks, Neil. And when people gain that control over their lives and environments, that is when their health and well-being is enhanced. And there's plenty of evidence for this. And we focus a lot on the 3 C's, building the connections, meaningful connections between people, or when they themselves build those meaningful connections. That helps to build, to help communities and connected people to take control, because they gain confidence to do that. So people need to be connected to be well. And we have the 6 features of health creating practices, which we developed from the perspective of those communities whose health had improved over a period of time. This doesn't normally happen on this slide, I just want to say.
No, I apologize for it, Mo, and it just keeps moving on. So
okay.
Yeah, it's nothing to do with encouraging you to speed up at all.
Okay, so they are listening and responding, truth-telling, a strength focus, self-organizing, power shifting, and reciprocity. And our first session, which you can see online soon, went into this in a lot more detail. So if you take those slides down, but the important thing there is to say that professionals can help to create those conditions for communities to become well. Communities can do health creation and do it all the time on their own, and we all do that to some degree on our own. But professionals can create the conditions by working as equal partners with communities and doing what matters to those communities. So this is about enabling communities to lead and take control. And so hopefully that's a quick introduction, and it would be good at some point to talk, Bola, about how the Health Creation Alliance as an independent movement might support you further with this programme. But what we're saying is that good relationships and connections are a very significant part of addressing health inequalities. And more importantly, they're a very significant part of how you sustain that work. You won't be able to address health inequalities without good relationships of all sorts. And I just want to Alex McCraw was supposed to be doing this session, but he wasn't able to join us this morning, unfortunately. He's one of our lived experience members and a director of the Health Creation Alliance. And he wrote a blog last summer, and that blog I'm hoping will pop up in the chat box very soon. It's called Building Back Together, My Vision for a Healthier Future, Communities and Contacts. And in it, he touches on his own struggles, and he says this. He says, the biggest moment of improvement was initial points of contact, friends or family, and more so over time, those who I have established connection with in my community, in my network of connections. Is this the same for most people? The answer is yes. So it's not principally the relationship between the service and the community that's important. That is very important. It's the connection with each other that helps to build that confidence, and is first and foremost the informal networks. And what we find is that strong informal networks within communities helps people to engage better with services as well. So it is later about the relationship between services and communities. We're talking here about communities of interest, communities of identity, and communities of geography, because individuals identify with whoever they want to be connected to. That connecting and belonging are at the heart of good health. So Alex's blog is actually a great prototype, we felt, for the Core20plus5 Connector program. And it was written before the Connector program. In it, he says, I think it's time to evolve what our current perception of the frontline is and bring in a new role to create that link between people and services, a role that can become the initial point of contact because we would be from the, because they would be from the immediate community, a team who would know the language, the barriers and challenges, but most importantly, would know the people. A community service bridge, there you are, CSB, a new acronym for us. A community service bridge worker, being from the community, based in the community, for the community. With Alex and with many others from across our membership, we've played a significant role in the Core20plus5 programme, and as it's developed with NHS SCW, with National Voices and Healthwatch. And our role, we felt, was the important role for us, was to support the development and maintenance of a positive power dynamic between the communities and the connectors and the services, because that power dynamic is all important at the frontline relationships. It can drive transformation across whole systems. And that's what coming of age is all about, driving that transformation from the right kind of relationships in the community and between the community and the front line. But that power dynamic can so easily get out of balance. It needs constant, ongoing attention. And I'm going to leave it there.
Thank you very much, Meron, for giving us an overview and explaining what health creation is and what we're trying to achieve over here. At this point, I'm going to hand over to Rachel Watts. She is the Program Director, Transformation NHS South, Central and West. She's going to speak about the connector programs and the sites. Over to you, Rachel.
Thank you, Giles. Good morning, everyone. So my name is Rachel Watts. I work for NHS South, Central and West. I'll tell you a bit about who we are and how we fit into the mix, and then I'll just cover some key principles of what the connector programme is about. So at NHS SCW, we are a care system support organisation. We work across the south of England, but also nationally. So with Bola and her team as system partners, and we join the dots between health and care. And we do that through service transformation and also through some essential system support. So we've got a range of teams who do a range of different offers and supports across systems. How we fit into the Core20 Connectors programme is we were commissioned by Bola and her team in NHS England to design, develop and mobilise the Core20 Connectors programme. So that started 12 months ago. So we've got 2 waves of the programme who are live. We saw on some of Bola's slides earlier that the connectors are one of the framework initiatives that NHSE are putting in place to move forward the Core20plus5 agenda and framework. What the connectors programme means is that there are funding opportunities for systems to deliver local projects, and we're going to hear from some of those local projects in a few minutes. what I wanted to just touch on was some of the principles and purpose of the Connectors programme. So the Connectors programme is similar to some other community-based roles. So it's built on the learning from the vaccine champions, social prescribing link workers, and other such really successful roles. And it's built around the principle of empowering local community leaders to take action and to deliver change on health inequalities. So it's an assets and strengths-based model that we co-designed 12 months ago with colleagues from lived experience, alongside colleagues from the Health Creation Alliance and Merrin and her team, as well as National Voices and Health Watch England. So it's a very partnership approach in how this model's been designed. Neil, could you pop the slide up, please? When that's loading in a second, what that will show us is there's a real balance and tension in the Core20 Connectors programme. So the principle of the programme is that connectors themselves are, on the left-hand side, a voice to the system to influence barriers and enablers at a system and a service level, to really hear those challenges on the ground and those opportunities for change, as well as impacting and influencing on health inequality priorities within their local communities. So a key purpose of Connectors is to be from those communities of identity, experience, geography, however that identity works for them, and to influence and impact on health inequality in their area. But importantly, the balance and the tension with the system and impacting on those barriers. How the programme is implemented and what that concept looked like at a local level is really different depending on the project. So if I could have the next slide, please. I said a moment ago that we've had 2 waves of the programme so far. So we've got 21 Core20Plus Connector sites. When we say sites, we're referring to an ICS who has some project funding, and that site could be at a local level, it could be a neighbourhood level, it could be ICS wide. So depending on the lens that that local system has taken and which Core20 plus population they're choosing to work with. The way the model works is ICSs receive funding for a project, and that's delivered through a VCSE or a Health Watch delivery partner. So some locations have more than one delivery partner, some have a single delivery partner. So we've got 30 plus VCSE or Health Watch delivery partners working and delivering the Connector programme. And as Bola highlighted earlier, the plans are to recruit 400 plus connectors. We're up to, I think, 137 at the moment. So hopefully when we hear from some of our live sites, they can give us some reflection on progress and where they face challenges in being able to mobilise the programme. So hopefully that gives you a bit of a focus of what the Connectors programme is. If I can just have the last slide, please. Sorry, Nia, just the last slide. It gives a bit of an overview of the types of clinical focuses that different projects are sharing across those 21 live sites, and also some of the health inclusion groups that particular areas have chosen to focus on and to work with. So you see a whole range of different clinical areas and a whole range of different communities are being worked with through the programme. And that's going to be some of the really interesting learning that's going to come out of this work, is what makes that work, and some of the discussion I hope we can get into today is how health creation can help to mobilise and to act as a catalyst to these projects and this work being successful. Back to you, Charles.
Thanks a lot, Rachel, for sharing those, thoughts with us and telling us a bit more about what you do. So at this point in time, we're going to hear from some of the connector sides. There are 2 sides we're going to hear from. The first is Leicestershire and Rutland Connector Programme. And to do that, we've got Kirit Mistry, who is chair and founder of South Asian Health Action in Leicester, and Khadija Amma Sharif, who is the CEO for Sharma Women's Centre in Leicester. And then we're also going to hear from the Shropshire, Telford and Wrekin Connector Programme. And that will be Neil Lloyd, who is the operations manager of Cube. So over to you, Kirit and Khadija, to kick us off.
Good morning, everybody. It's great to be here and hear some wonderful things about the Core20Plus programme. I'm one of the delivery partners in Leicestershire and Rutland ICS, delivering the Core20 Connectors programme. So can I have the first slide, please? Have the next slide, yeah. Well, the focus of our programme is about improving engagement and contribution to reducing health inequalities in some of the most deprived Black, Asian, minority ethnic communities in Leicester, Leicestershire and Rutland. And we focus on 3 areas. We know we can't do everything, but 3 key clinical areas: cancer, hypertension and respiratory COPD. There's 3 delivery partners: Shamma Women's Centre, Equality Action and SAHA. Shamma Women's Centre, we've been around for 37 years, and some of the departments, basically deprived areas in Leicester City. And we've had experience of empowering Black, Asian, minority women in Leicester in many areas of education, including health inequalities and closing the gap. The women that we're dealing with in this programme have multiple barriers. They have cultural barriers, language barriers, poor literacy skills, lack of understanding in particular in terms of health education. But there's also other socio-determinants of health, factors such as poor diet, exercise and smoking, which play a really important part. Next slide, please, Neil. So for us, the community connectors have a very important role in providing that kind of interface and contact. But the contact for our connectors to be meaningful, we've recruited a programme coordinator with a lived experience, multilingual lady, and we plan to recruit 10 connectors throughout the programme, but we've recruited 6 connectors with lived experience across the 3 clinical areas. But very importantly, what we look for was the passion and the motivation for these individuals to want to create an impact and to make a difference in their community in terms of health outcomes. And that's a very important ingredient. But to enable them to do that, to have the confidence to turn that into something positive, we've got to make sure that we have the kind of training and support and knowledge they need to do that. We already had an initial development session, which is co-produced by NHS colleagues. And I must stress, we are one team, and that's really important, working at as one team, and the connectors see us as one team. And we use that session to identify skills and gaps and support they needed. Now, this was actually going to feed into a training and development programme with it's a collaboration workshop on the 1st of November with our clinical needs. But very importantly, I think it was important to get feedback from our connectors in terms of what they felt they needed to do the job, not to sit and just devise a programme thinking we think this is best for them. But in terms of lived experience, in terms of what impact they've made on themselves and on their community. But one of the things that, in terms of my role, I've learned, and as a community leader, is that by giving the only way you can give control to the community, and this is reflected in Health Creation's principles, is about empowering women in health education, and they want to learn, they just want that opportunity, and providing them with the knowledge of how to access NHS and other support services and bringing those NH services close to them. And we've done that through running a series of awareness events, and they've been very, very successful. But also what we aim to do, and we'll continue to, is provide insight. And it's about addressing enablers. What would it take for you to go for your smear test? And I want to kind of illustrate Health Creation in a real life kind of example. Next slide, please, Neil. Talent, she's used her personal experience avoiding having her cervical smears for over 7 years, and she identified it was basically because she didn't want to remove underwear, and this resonated with many Black, Asian, minority ethnic women that she spoke to. So she actually did something positive. She produced some lingerie designed for clinical examination, where you don't have to actually remove your underwear. There's poppers there, and this kind of gave the strength and focus. And so she produced these, test marketed them, and then provided samples to a local GP. And the important thing is a local GP actually listened to what the barriers were, listened and responded, and that GP's actually improved an uptake in terms of kind of women taking smears. But very importantly, she also wants to use this passion to continue and work as a connector. I think for her, the highlight was when one of her friends had a smear test as a result of this underwear, and detected very early on for cervical cancer. So it's about empowering communities, listening to communities and acting upon them. Next slide, please, Neil. Well, for us, health creation has to be co-production. We have to be one team. It's a joint-up approach to meeting health inequalities, and it's got to be driven by the community. It won't work otherwise. And working with our clinical leads, for example, our long COVID lead, there's areas, you know, the communities don't even understand, Black Asian minority communities, that they've got long COVID. So again, we're going to use that insight from that to feed that programme. For us, connectors are going to be a vital interface and have been between PCN, social prescribers, and also faith and community groups. The community needs to know who to go to, where to go, and why, you know, what is the impact if they don't go for their smear test. But very importantly, our connectors will be providing insight. We're looking at quality, not quantity. It's that little gem that could change somebody's life, like those pop-up pants. But I think to keep that confidence of the community and keep them engaged, and is recognition of input from people and those communities. It is a slow burner. It will take time, but it's about building up trust and creating that sustainability. Right, so I think Kirit will be speaking next on behalf of Sahar.
Yeah, thanks. Thanks, Khadija, for outlining how we're delivering it in Leicestershire and Rutland. And as you said, it's a team, and it's working with the 3 delivery partners, but also with our ICB and the clinical leads. So I think one of the things that we've tried to do in the initial stages is really about through word of mouth, through our community networks and contacts, we've identified connectors who've lived experiences from cancer, hypertension, and respiratory. And it was fortunate we did a project with National Voices and NHS England last year around long COVID, and we focused on South Asian communities. And what we were finding was the barriers to people getting support around long COVID. So we already identified some connectors who lived experience around respiratory. So that's been fortunate that we've got them, and now we're just going to be working with the connectors. We are going to do it in a phased way. So we've got a target of 10 connectors per organisation, per delivery partner, but we thought we'd kind of have a phased development around connectors, and that way we can ensure that we provide the right training. We kind of co-design, co-produce training that's going to be relevant with the connectors and with our partners and with the clinical leads. And how we've actually looked at community events that we over the summer. We had a number of events that we were engaging on and creating visibility around this new, what we're doing with Core20plus5, and also thanks, Neil. So where we got the opportunity to create visibility, we had large events happening, some religious events, some cultural events as well. So we kind of were present there. We kind of engaged. We kind of tried to get some initial insight from people directly around what are their challenges, what are the barriers that they're facing, around some of the clinical areas that we're going to be addressing. And through this, as I said, we recruited people just by that direct contact, but also we've gained some insight around some of the challenges and some of the institutional barriers that the communities are facing. So we've just identified somebody who's told when he was going through his initial consultation around he had a heart attack at the age of 42. He identified a growing lump in his pelvic area, and he asked the clinicians to look at that, and 6 months later he gets his biopsy, and he's now been diagnosed with aggressive lymphoma. So these are the kind of things that we're actually capturing from the community in terms of this late screening or the lack of consultation or understanding around those kind of screening when the appointments happen. So I think one of our connectors, the way the connectors are going to work is they're going to be our real kind of eyes and ears in the community, using their lived experience, but at the same time capturing that wider insight as well. And what we will be doing is supporting our connectors with the clinical leads to develop awareness packages that they can go out and raise awareness on those 3 clinical areas. I think there's one, I think there might be another slide. If not, that's fine. And we kind of piggyback on a number of events that happened. So the cricket club did a community event, so we kind of were present there. And again, we've kind of used the vaccination awareness events that we've been engaging with, working locally with our CCG and Public Health through their community champions program as well, to kind of further engage. And most importantly, our strapline is working on 4 E's: engage, educate, empower, and explore. So exploring a number of opportunities, and we're glad to be part of this, the delivery partners for working on this project. And hopefully we're going to be looking at, it's not a short-term fix, as Khadija mentioned. It's about how do we ensure that at the moment, health inequalities is on the agenda. Lots of resources is coming around health inequalities. How do we ensure we kind of create a sustainable kind of initiative program that's going to be embedded in the 3 clinical areas that we're going to be working on? So I think I'm going to stop there, and obviously we're happy to answer any questions later on or whenever. So thanks, Charles, and thanks, Khadija, as well.
Thanks, Khadija and Kirit. So now we're going to hear from Lloyd, Operations Manager of Cube.
Good morning, conference, and thank you very much for the opportunity to be with you here today. My name is Nia Lloyd, and I am the Operations Manager at Cube. Unfortunately, this morning you have, I'm afraid, pulled the virtual short straw, as all of the staff connected with this project all have other Cancer Champion commitments. My role is to line manage one of the project officers, and staff really didn't want to miss out on the opportunity of presenting to you this morning. But I do apologise at the outset for my lack of detailed knowledge regarding this project and the work that we are undertaking. What follows, though, is a generic presentation of our work to date. And some of the first points will be information that you're probably all very aware of. Shropshire and Telford Cancer Champions is a joint project with the Ling and Davis Cancer Fund based in Shropshire, and Cube, which is a Shropshire and Welsh Borders community hub based in the market town of Oswestry. If you can have the next slide, please. Is the slides coming up? Thank you, Neil. Excellent. As you all already will understand, the project is part of the Core20plus5 initiative, and our aim through this project is to support the reduction of health inequalities at both a national and at a system level. The approach defines a target population cohort, the Core20+, which is the most deprived 20% of the national population. It also identifies 5 focused clinical areas that require accelerated improvements. The clinical areas that this project focuses on is cancer diagnosis, where the aim is by 2028 to see 75% of all cancer cases diagnosed at stage 1 or stage 2. The health inequalities that we are working on, is the plus population groups that are disproportionately affected by health inequalities, including ethnic minority communities, people with learning disabilities, those experiencing homelessness, people with drug and alcohol dependencies, vulnerable migrants, along with Gypsy, Roma, or traveller communities, all of which we engage with here at Cube at a grassroots level on a regular basis. Volunteers are a very large part of our work within the project, and our aim is to recruit volunteers from within our target communities, providing them with confidence to speak about cancer within their communities. One of the most important aspects of this project is, of course, to ensure co-design through the ABCD approach, acid-based community development. Although still in its early days, we're working with community partners, leaders, and local groups, and that is proving to be particularly successful in creating a cancer champion's voice in our local area. Michelle Moore and Holly Corrigan have been appointed to be our Cancer Champion Coordinators for Telford and Wrekin and Shropshire, respectively. And today they are at the Gurdwara in Telford, filming with a group of Sikh ladies for a bilingual video that we are putting together, highlighting the project and how the selected communities can get involved. Can we have the next slide, please? So what exactly is a cancer champion? We believe it to be a successful cancer champion, people need to at least have an interest in, or indeed have a lived experience within our target communities. That they are able to reach out into their own communities and have the ability to communicate with people in the target groups. We will work with our cancer champions to understand experiences and perceptions regarding cancer, screening, and how to prevent cancer. Cancer champions will look to encourage local people to take up screening in their communities and also to report potential symptoms. Working together, we look to encourage feedback from experiences that people have had to be able to gain a wider understanding and insight of cancer screening, prevention, and symptoms. All of the champions that we will work with will be supported through the project through a dedicated training programme, along with resources that will be available on our soon-to-be-launched website, along with numerous leaflets that will support them in their role. The next slide, please. What we are looking to achieve. So we're looking to create a movement of motivated local cancer champions working at a grassroots level. That has been a success so far. A dedicated cancer charity working with a community organisation, we've been able to easily access hard to reach project target groups. Developing resources. We look to develop training for each and every one of our champions. We look to develop a website and videos and other resources that can be shared within the target communities that will help break down those barriers in relation to cancer. We want to understand our communities. We want to listen and learn from what we have been told and generate insight and understanding of what can be done differently in the future. We look then to achieve feedback. We want to bring together the voices of the people that we work with in order to be able to forward this information back to NHS and other partners that we're engaged with. And also, of course, look for improvements as to what can be done better. Most importantly of all, we look to increase early diagnosis of cancer, along with increasing the numbers taking up cancer screening. Next slide, please. So still very early days, but the feedback has been extremely positive, and we put this down to our connected community approach, working and listening to the communities that we're engaging with. Going forward, we only want to develop this approach, and we would welcome interactions and feedback from as many of you as possible. Tracy will be part of the panel this morning on our behalf, and I'd like to thank you very much for your time this morning. And if you do have any questions, particularly about the Cancer Champions project we're undertaking, please don't hesitate to contact either Holly or Michelle on the email as shown. Thank you very much.
Thank you very much, Naya, for that and for sharing what you're doing. So, it's been brilliant hearing the various presentations. We're just now going to move into a plenary where we're going to have reflections from the site activities. And, the main focus or what we're looking at is whether Core20+5 can be a catalyst for embedding and sustaining a health, creating dynamic and relationships between services and communities in the long term. And on our panel this morning, grateful to have Marie Andrea Gameshi, who is the President and Managing Director of UK Ireland Innovative Medicines within Novartis, Don Shepherd, who is a community leader and informal connector from Devon, Townstyle, Devon, and then Dr. Amina Verity, North Lewisham PCN, and that's their lead for health inequalities and community of practice lead for health equity. Khadija, who you've heard from, CEO Shama Women's Centre in Leicester, and then Tracy Jones, Deputy Director of Partnerships and Place, NHS Shropshire, Telford and Wrekin. So this session, the plenary will be chaired by Rachel. So over to you, Rachel.
Thank you, Charles. Great to see everyone joining us. We've got a couple of new faces that Charles just introduced there, so great to see everybody. I don't think Dawn's been able to join us today, unfortunately, but it looks like we've got a real range of perspectives that we're able to talk to today. There's a number of sort of questions and discussions which have come up in the chat, which has been fantastic. So if there are any additional questions you particularly like flagged, then we'll see if we can add them to our agenda. I wonder if I wondered if you could kick us off with a bit of reflection on one of the key principles of the Core20 Connectors program we've talked about is impact and influence in a community on health inequalities, but as well as system listening and system taking action on those barriers. And I'm wondering if you could give any reflections on how you think health creation can act as a catalyst for that system listening to happen.
I think there's got to be commitment on both sides and a real kind of drive to make a difference and to listen. And I think we're very fortunate. Our ICS, our ICB partners, amazing that they're really kind of bought it. It's about buying into the whole kind of concept of connectors in the community. Delivering the solutions. We know what the barriers are. Generally across the country, what the barriers are. But I think it's about a willingness to listen and let the delivery partners continue to do the work through those connectors and to listen to what's coming out of that. And it's all about insight and acting upon it. And I think if that doesn't happen, it's not going to work. And it's that loop of feeding back to the community. You went to this event and you came up with this idea and feeding back to them, this is what's happened as a result. I think that's really important. If that doesn't happen, they won't participate, they won't engage, there won't be that kind of, and I think what I found over the years, particularly with women, is all these kind of Black Asian minorities, they don't want to know, they're poorly educated, they don't care, they've come from abroad. That's not the case. They absolutely want the opportunity to make a difference. And I'll give you an example. For cancer, we worked with a local trust, University Hospital Leicester, and they wanted to kind of increase the rates of, testing, smear tests, because they were pretty low. So we did a bit of talking to them. So why don't you bring in, we had an event, health, why don't you actually bring in the equipment that you use for cervical smear tests? And they did, and the ladies go around picking it. Always, this is what it looks like. And it's and then, like I said, it's about bringing the NHS closer to the community rather than having that big gap. It's bringing NHS into the heart of the community and letting and then they were then advocates for other women. No, you should go. Look, I've seen it's nothing to it. So that is just one little example of what can make a difference, and it's those little things that are going to have a really important impact in terms of health creation.
Yeah, that's a really helpful reflection. Thank you, Khadija. I wonder, Tracy, did you want to add anything from your sort of system perspective? If you're seeing anything different in terms of that system listening and what that looks and feels like, and potential routes and resolution to that?
So in terms of our project at the moment, it's obviously in quite early stages. So we haven't followed through our feedback loop into the system. But what we have done is we've started talking to the system. So one of the very first things we did was actually an event for all our system who are involved around cancer. So that was our PCN cancer leads. It was our other voluntary sector workers who were working in cancer, and bringing them all together so people were aware of the programme. So then it's thinking about how we embed that into our processes. And there's something that you've just said, Khadija, that made me think about how I need to be talking about the change, because sometimes people are worried that when I do my work reaching out, asking for people's perceptions, they worry that the change that's going to be asked for is going to cost lots of money, it's going to be huge, how can their frontline staff who are already pressurised deliver the change? But actually some of these changes can be deliverable, and they're small changes. And I think it's about my role as the ICB lead for this project is as much about supporting Cuban, Ling and Davis, who are absolutely brilliant as delivery partners and know their work. But it's supporting the other part of my system. It's supporting almost the NHS colleagues to understand that in doing this work, there will be things that we can change. We are in Shropshire, Tafton and Wrekin, a very financially deprived system. We don't have oodles of money, but my principle is we don't necessarily need expensive solutions. And so I think that's one of the core messages that I'm working on internally with my own system, is that sometimes, now there will be things that will have financial implications, and then it's the feedback cycle, because the other thing is we talk with people, we listen, we hear, and sometimes these things aren't easy fixes. I was reflecting on one of the comments around maybe access to GPs. Well, we know that's not a quick fix, but if we're honest and transparent about it, we can have those conversations. So I think the one thing that I'm reflecting on is that when we're changing in the NHS, it isn't always about the money.
It's really helpful. Thank you, Tracy. Amina and Marie-Andre, you come from sort of quite different perspectives. I wonder if you wanted to give us a few minutes of reflection on what you've learned and heard today about the Core20 Connectors program, and if there are any particular reflections from your work you particularly wanted to share, or questions you wanted to pose for consideration today. Amina, did you want to go first and give us some thoughts and views?
Yeah, thanks so much, and thanks for having me here. So I'm a GP. I work in Lewisham in South London, and was the health inequalities lead for our PCN, and now have stepped up to mentor new health equity fellows across Lewisham. I think there's some really exciting innovation and enthusiasm for this programme, and I think there's some great examples that we've heard today. I think one of the challenges I just want to put back to everyone is that actually a lot of the Core20plus5 model to us as frontline clinicians is pushing us into business as usual. So it's identify a population, identify disease-specific areas, find that population, and then do a program related to that. And I think when you think about Lewisham, for example, 60% of our population fall into the Core20 plus population. So 23% are in IMD 1 and 2, 35% are BAME, and we think roughly 1% from the best data we have are in the plus group. And so actually that's the majority of your population are suffering, you know, from significant health inequalities. They are not achieving the same health outcomes as other people in the country. But then what we're being asked to do is focus on 5 key clinical areas and do a program on hypertension, do a program on COPD, do a program on this. And actually that pulls you away from the kind of health creation, allowing communities to think about generally developing healthy behaviours and lifestyles. And I think, unfortunately, unless there's a change in the funding model at general practice's front door and in the system, this is never going to translate to the kind of changes that we want to see. We're chasing, you know, the investment and impact fund. We're chasing the PCN, DES, direct enhanced services. We're being told to focus on, you know, QOF and these sorts of things. That for those who aren't clinicians, these are like the indicators that GPs are paid for. So how many of your patients have a blood pressure that's controlled? And what that means is that you develop programs that basically are, okay, how do we get that payment? And locally in Lewisham, we were doing some really exciting work, creating a community forum, hearing from the community. We had a community link worker, some really exciting, you know, innovations, and the community coming up with some lovely lifestyle medicine approaches, and a community hub where people are going to, you know, there's an Ivorian women's group who are going to run a mental health session for their community because they think it's, you know, something important. And yet, you know, the clinicians are telling me, how many points on the IAF is this giving? How much money are you using on that? This can't happen. And it's no one's fault because the system is so pressurized. You know, general practice is in an absolutely terrible state at the moment. We're hemorrhaging staff. And also, you know, we're paying, sorry that I'm this is all a bit negative, but I will get to the positive part. The other thing that I really wanted to mention is about recruitment and retention. So how much are these community connectors being paid? How much are we valuing people in these roles? So we've got a social prescribing community link worker who's doing, I think, very similar work to the community connector by another name. But I have been fighting to get her to be paid more than £24,000. It's not even a London living wage. And that's what the NHS is paying someone in one of these roles. And she's going to go, she's going to leave because she can't afford, she's on the fuel poverty payment thing. And it's just shocking to be in that position when you're asking the system, this doesn't cost money. We have to have this approach if we want to address this. And I think, Core20plus5 does help us to kind of focus clinicians and the system on thinking about your population. But when you work somewhere where you've got wide levels of health inequalities, there has to be a holistic system-wide approach. And I think, Merrin, with the call to action at the beginning, that we have to think more about the funding models that put the community in the driving seat. So yeah, that's my 2 cents for now.
That's really helpful reflections in there. Thank you, Mina. There's a number of things I'm sure we'll pick up as we do some questions in the session next. Marie-Andre, I wondered if you wanted to give us a few minutes on your thoughts and reflections on what you've heard so far and some of the questions and challenges that have come up.
Yeah, no, absolutely. And I think, the first, kind of the elephant in the room, people might be going like, why is the person running Novartis UK in this meeting and what's the relevance for the pharma industry? And I think that's really important because we, have the vision to be part. I love this. And I was looking in the chat, it's about holistic and how do we also play a role in that? And I do think the Core20plus5, and we worked a lot with Bola and team, has really changed how we look at how we approach healthcare also as a life science industry. And I think that's really critical. If I look, from a Novartis standpoint, our portfolio kind of ranges across the Core20plus5, and it's really changed that mindset of, a couple of years back going, well, I've got an innovation, I need to get through NICE and get access to. How do we look at the pathway from the beginning? And how do we make sure that when the access is in, there's other elements of interventions? Where do we play a role? Core20plus5 is also sparked discussion on clinical trial recruitment and making sure that is diverse and inclusive as well. So there's really different elements. So it was great to listen to the connector, but also always good to rehear the Core20plus5, where it comes from, because for us, it re-challenges what role we can play in this holistic approach. I think there's a few things that come. In some elements, it's around population health, and how do we make sure, again, looking at our own belly button, making sure that we don't just focus on that access, but how do we make sure we can help the system intervene in different ways to make sure that the patients present, but also how do we focus on prevention before they present? And it's always kind of this barrier between industry and healthcare system, and how do we make it together, and how do we figure out where we can help? I think the point on early diagnosis is a really important point as well. Where discussions of this morning also sparked that. As I said, one is on clinical trials, right? Core20plus5, how do we also use that data to make sure that the trials are recruited in an inclusive and diverse standpoint? That also provides access. I think there's a really important element in terms of data. And how do we use, so we've had, this program around data around the health inequality tool to help identify. And again, our role is to help, is not to solve the problem, but what can we provide as resources to be able to help? And this is something that we've done in the heart failure space, and also in the sickle cell disease space. So I think there's some elements around the trials, around data and how we can support with data, and then around population health to make sure that we also, our own belly button, don't look at just the access as in access is given. It means every patient, regardless of postcode, will get the same access. But how do we look that broadly? And that's a pledge, the team has made last year around health inequality to make sure that we kind of turn around our thinking internally, so we can best support externally. And look at this data to say, in region X, I might provide a support that's very different based on that data around health inequality that will provide in another region, right? That's our role, to provide the right programs as well. So really wonderful to be part of the panel and to be part of the discussion, because I think that's the point of a holistic, is trying to get all the partners together to advance on these important topics.
It's really helpful. Thank you, Marie-Andre. I wonder if we can pick up on some of the points in the chat and some of the themes of what we've been talking about so far. It's feeling like relationships are going to be really, really key in connecting with communities as well as driving that system change? I can see both Khadija and Tracy nodding here. I'm wondering, Tracy, if you could give us some reflection on how you think relationships are going to drive system change within your system, what those sort of most crucial linkages might be, or how that might best work.
I think some of the, if I think about our delivery partners that we selected Cube and Lincoln Davies because they were both situated within the community and they were also recognised experts in the field of cancer. So the relationships we chose, the people we chose to work with, reflected what we needed to deliver. But I think the key relationships that we've got, which are much broader than our delivery partners, is actually not seeing this as something separate, as a core connector program separate. This is actually part of the much wider work that's happening with the local authority and the voluntary sector as part of ICB's roles. So I think that community relationships incredibly important, and we have those. We're not starting at ground zero, but we're asking people to do something slightly different. And that does take time, because what we're not just asking people for their opinion, because in terms of pure engagement work, we could have just said, oh, we'll ask people what would make it better for them. This is doing something that's slightly different, which isn't about us NHS workers asking what makes the difference. It's about equipping, skilling, and allowing members of the community to work with other members of the community. So it's a different type of feedback. So that's my one. Looking to my left or right, I don't know which is which, so I've probably just said the wrong one. But looking to my other side, I've got the real decision makers in my organisation. I've got the people who hold the purse strings. I've got to think about sustainability. I've got to think about changes. We've got to listen. If I'm really hearing that what's happening in one of our services is just disenfranchising a whole section of my community, whom I know evidence shows me has poor outcomes. So I need to be thinking about building the relationships upwards, as well as building on the relationships downwards. So I would say my community and our relationships with the community around this topic area and the input and flow is good. But I would say that there is a lot more work for me to do in terms of the influence and the influence upwards into my system. So I think there's two lots of relationships that we need to think about.
It's really helpful reflection. Thank you, Tracy. Khadija, in your work, it feels like you're working at that really community focus level, and some of the comments in the chat around the pace of change and trust being the fundamental building block and starting point for that. Thinking about the health creation approach and model and the 3 C's around control, contact, and confidence, how much do you think that a health creation approach and model can really support what you're already doing at a local level, and can really help and support drive the connectors in their roles?
Well, I think, and to be honest, had not known that much about health creation until recently, and I looked at it and I kind of translated it into what we were doing. I think, well, this is what we're doing anyway, and this is what's working. So I think that's kind of proves in itself that it's a good formula, in the sense of, you know, it works. But I think in everything, it has to be embedded in everything we do within the whole ICS, within the community. It has to be a vital part of that. And it's empowering those communities to make those decisions and want to make those decisions to change, and giving them the resources to do that. So this is, again, and I'm going to talk about, if you're talking about sustainability, that again, there's a financial aspect to it as well. You know, there's got to be money invested in organisations that do deliver on the ground on those communities. At the moment, our connectors are volunteers. They're doing this role because they want to do this role, but there needs to be some kind of incentives. You know, you've done really well at this, and you're passionate, and we've developed you. You know, yes, we can give them a certificate of recognition, whatever, or some kind of qualification. But again, they may want to go on to, you know, kind of more of a paid role in terms of recognition. So that needs to be, you know, kind of those resources need to be made available from the NHS to invest in those people, those connectors, community connectors. So yes, I think it's winning formula. I think the commitment is there, the drive is there to make a difference, and it's about keeping that momentum on it, not doing it for a year and saying, well, you know, we've got no resources to continue. I think it's about planting those seeds, letting them grow, and embedding this whole approach in terms of you know, the whole kind of landscape for the ICS and the community. And I think it's real potential there, real potential to make a difference.
It's really helpful reflection. Thank you, Khadija. Marie-Andre, I was wondering if you could give us some of your comments as someone who's not involved in the detail of the Core20 connectors as a program itself, and some of the comments that we've been talking about in the chat are picking up that it feels that there is a potential tension between working with communities about their priorities and what they think and what they want to focus and work on, and a set of priorities, a set of clinical focuses, and it feels that there's a potential tension between how can you work in a health creating way with communities and also then focus on 5 core clinical areas. I wonder what your reflections would be on, is it possible to do that, and what would some of the opportunities be?
Yeah, so I hear the I guess the polarity between the two, right? Because you have to be at the community and down at the place, etc. And interestingly, you know, I was reflecting in that discussion, and I think what Amina, you were saying as well, between the co-op, etc., and being pulled in those different directions, I do think it's feasible. And I also, it's something that, you know, I reflect kind of in my day-to-day role is also a challenge that we have, because we have this kind of national approach, but we know that where we're going to be able to support programs is in the community. That's where it's going to make the biggest impact. And I do want to come back, for me, the key point on that is around data, and really having that generation of data to identify the areas, to be able to justify kind of that community, and then being able to show the impact. I love, and I think it was Khadija that shared the underwear for pap smear. Love that, because that's a great example of absolute community. And actually, if you think of that example, you could actually bring it at the national level, because this, if you looked at data of where the issue would be, I think, you know, I'm thinking you can take it internationally. So there's much, and I think those are the type of examples that if we also share, what's that local example, what impact it had, and therefore could it become kind of helpful for other areas in the other community. So it doesn't, because I think that's always the pressure is going, if you go community, will it just be for that one area? And I love that example, because you could actually take it across multiple that have the same issue. But I agree, it's a polarity and it's a difficulty to always have those, but it's how do we show the impact of community? How do we show it could be scaled? And I think then the two can reconcile.
Really helpful, thank you. I'm coming to you, Amina, I promise. I think one key reaction, arms we're going to get in a minute. For me, it's feeling like there's a scale and spread and a learning and how are we sharing and scaling what the opportunities are. So Khadija's example there, how can that be national, international spread? It's going to be really important learning from the connectors. Amina, did you want to come in?
Yeah, I think just picking up on Marie-Andre's point about the data, and I think that is a really key part of kind of the approach that we've been taking locally. And we're working with the population health team to give like a nice data pack to each of our fellows to show them for their primary care network, okay, what is the landscape of health inequalities? But I think part of that problem is because of the way that we think about in the system is that this program is like 2 years long. Are we, like, Khadija, can you say for definite you have seen an increase in cervical smear rates, like categorically, numerically at this point in time from that intervention? And I think the problem is that the NHS and the system partners are very unforgiving of things that take that building trust and time. And I think one of the things that we really have to shift away from is allowing, you know, things just get canned after a year because they're like, oh, it didn't do anything. Look, you just started having conversations, and everyone inside of it, and I think lots of people in this room are like, yeah, but we're building the trust, and you've got to give it more time, and then we'll see. And also, I think, Ollie, you put something in the chat about the diabetes program, like the community's telling you that they don't want to have a disease focused target, but then how do you show that you're delivering on that? Are you going to be measuring their blood tests so that you can show that this, you know, holistic approach is leading to a reduction in blood sugar levels. And unfortunately, we are just being pushed and pushed and pushed in every direction to kind of take that approach. So I think we really need to try and find what it is that will allow us to kind of have these innovative things. And it seems like people like yourself, Tracy, in like ICS leadership roles can enable that, but then there has to be socializing of that, like all the way down the system, to be like, look, we're happy for you to do this, we're happy to wait for indicators, keep going, like we're really supportive of you, so that when the kind of dissenters in the group are going, no, but I'm not getting any funding, I'm not meeting my IF, and I'm not meeting my DES, and I'm not meeting my QAF, you know, someone is saying, look, don't worry, we can incentivize, we can pay you a bit for that now whilst we wait to see if this approach works, or something, I don't know, something like that needs to come alongside it so that we can give these programs time to kind of develop.
It's a really helpful reflection. You touched on the question I'm going to come back to with about whether you think systems are capable of the scale of change that's needed to really focus in a health creating way. Do you think systems are capable of that?
I think, you know, today is a really good example of showing that there's a lot of like excitement and energy for doing something differently. And I do think systems are capable of it. I think ICS has provided an opportunity of kind of, you know, that holistic working with kind of social care, council, NHS, communities, voluntary sector organisations working together. It is the moment of opportunity. I just think, unfortunately, at the moment, the stuff that has come top down hasn't, for me, delivered on changing the narrative around how the funding model is going to support it. Because with the state that the NHS is in, and God knows what will happen after the next 2 years or how many other prime ministers we'll get through, we just, you know, we've got to like really make sure that we're not asking frontline clinicians to do things that they feel aren't, you know, are in their spare time or extra or this kind of thing. Like people have really demoralized on the front line, and I think that's another focus we have to look at.
It's a really helpful reflection, thank you. Starting to draw to the end of our time slot today, and there's so many other things that we could touch on and questions that we could get into. I wonder if as panel members you wanted to give us a last thought, be it a call to action to yourself or to someone else, or just your key reflection and thinking prompt that you've taken away from today. For me personally, it's going to be around that scale and spread of learning. How can we capture all of the learning that Khadija, Tracy and Nia and all of the other sites are picking up, and how can we scale and spread and capture all of that? That's going to be my takeaway and my challenge to myself. Marie-Andre, what do you think is your reflection from today?
Yeah, I think quite a few reflections, but I think most importantly, I think there's one on kind of the life science side, to continue to challenge our model with that at the very core. So I think that's really important. And then the other one is touching on what you said, Rachel, is what can be our role? Like my dream is to break that divide so that we can really have a holistic approach and, you know, bring all the resources that we can in the system. But what can be our role right now to scale, to take some of these ideas and help scale, and really, yeah, to be able to move on that focus.
Great, thank you. Amina, core reflection from you?
I think core reflection is there's lots of evidence that this approach is, that a health creation approach is definitely the mechanism for reducing health inequalities, and we need to push for the system to accept that and measure it in tangible ways that actually don't set us up to fail.
Very helpful, thank you. Khadija?
I think for me the reflection is the health creation model does work. It's got a lot of potential to do a lot more, and it's the way forward in addressing health inequalities. It's going to be a good investment in terms of outcomes for communities, for those most difficult to empower, but giving them that opportunity, I think this model can, and it's about listening and responding, very important for all those concerned.
Thank you, Khadija, that's really helpful. Tracy, final last word for you.
My final last words are, and I hear about the scale, and I know that we have to affect change, we will need scale, but I think we should never forget the individuals who are going to be impacted on by the work we're doing. So I think about You know, we talk about scale and we think, and if we start thinking on a large scale, it feels impossible. It feels, how do we change this acute illness focus that I see so much in my ICS to one where we think about individuals creating their own health with support from us. So I would just say, yes, we do need to have impact at scale, but never lose sight of the fact that all the work we're doing will have made individual impacts on individuals' lives. And those are my thoughts.
Thank you, Tracy. That's like a fantastic way to close this section. Thank you all for your views and reflections. It's been lovely to talk to you all today. Back to you, Charles.
Thanks very much, Rachel, and our panel members, you know, for that discussion and thoughts and reflections. We're going to continue with some further reflections from practice. And this time we're going to have Joe Trask, who is Macmillan Patient Experience and Health Inequalities Manager for the Our Cancer Alliance based in Cheshire and Merseyside. So I'm going to hand over to Joe.
Thanks very much, Charles. Thank you for the introduction with the longest job title in the world. It's really, really exciting. I've got 10 minutes to kind of bring together our reflections from the morning and lead that into our breakout sessions. I'd like to do this through a few slides. Hopefully, I'll have pulled together everything together. So could I have my first slide, please, Neil? Thanks so much. So my title is Making Health Inequalities Everyone's Business. And as we've been talking this morning, I keep writing the word everyone on my paper. I may seem to come from a different angle. I'm NHS focused. I work in an alliance. What I want to tell you is a little bit about my past. I was born in Bootle. So when we talk about Core20plus5, so that 20 is the top 20% most deprived group in the UK, according to kind of the deprivation index. Bootle's in the 0.5% area of top deprivation. So I grew up with that experience. And I think for Cheshire and Merseyside in Liverpool, we're looking at 50% of the population living in the top 10%. I'm sure no different to some of the areas you work in, but that is kind of the background I bring to this. I'm 30 years working in the community sector, kind of working with groups that experience health inequalities, representing their voices. And I'm recently 18 months into an NHS role for the first time. So that's kind of my background. The last 5 years before the NHS, I worked for Macmillan in a face-to-face role with people both experiencing cancer and significant health inequalities. And if that doesn't make you feel urgent about what you do, then nothing will. I feel that there's an urgency about health inequalities that perhaps when we talk about strategy and we talk about how we're going to make system-wide changes, we forget about the urgency on the ground kind of difficulties at the moment. I'm really, really interested in what Amina said about frontline staff, and that's kind of what I want to say. What we've decided to do at the Alliance is change the way we think about health inequalities by supporting our staff. Neil, could I have the next slide, please? So this slide here aims to show you that, you know, there's a traditional model, and even though health inequalities, you know, has, as we love to say, a spotlight since COVID, you know, I've been working in this area for a very long time. And the first thing we need to do is to acknowledge all the brilliant work. Tracy's just said it. We need to acknowledge that this stuff is going on everywhere. It might not have the names against it that we're currently using, but this stuff's brilliant. But what started to come in is this traditional role where we have a team that manages health inequalities, a dedicated worker, both in patient experience and health inequalities. We kind of think about that working in a silo. We've obliterated that where we work. What we want to do in the Alliance is create a fundamental shift within the entire staff team to empower everyone to tackle health inequalities and engage with patients themselves. So this could feel like a little bit left field to health creation. But where it brings it back to, and what's absolutely important about this, is that we're expecting every staff member to consider health inequality as part of their business as usual. It is throughout our project management program, it's throughout induction and training, and it's how we talk to our staff every day. And I work with a team of 50 people, and they're expected to bring the community approach and listen to patients throughout everything they do. And they can't do that without support and resource. So we act as what we call a facilitative legacy approach. So legacy, it's really important to recognise money. We were given 2 years to make these changes. And I completely agree with Amina about the long-term funding is vital if we want to make changes. And also, do we need results after 2 years, or do we need to say, what do we want after 5 years? So there's something really important there. Neil, can I have the next slide, please, about how we innovate with our staff? So before I go any further and talk about this slide, I just want to talk about kind of communities and patient engagement. When I arrived at my job, we had a patient panel, and I would, with great fondness, call them my usual suspects. They're people who are white, middle class, who've experienced a positive experience and want to give back in the system. And they are a really valid voice, but they are just one voice. We've spent an awful lot of time going out and working with both communities and patients to make sure that that voice is now much more varied. And so when I'm asking my team to speak and consult locally, they're actually not just listening to one voice, but a really good variety. So this slide's just to show you, yes, I'm asking the staff a lot and in the time that they already have, and we're asking them to change their approach, but they're not doing it alone. So the first thing we did was create some really great materials. These are accumulated from across the country, but also of a lot of our own stuff, so that when we say to staff, you need to think about what you're going to change, there is a backup for them. Neil, can I have the next slide, please? What else we've done? So we have a health inequalities staff network. So this wasn't really in the plan, but this is how these things happen. It came to me. I work in the Alliance, which supports cancer services across the region, and people across the region are coming to me and saying, I'm plugging away at health inequalities on my own in my trust or in my PCN, I need your support. So we created a staff network, and that's a monthly meeting, and it simply brings people together to talk about what's going well. And crucially, I wrote down what isn't working, where are our challenges. So this is almost bottom up. This is about saying in the NHS, okay, what are we going to do? And alongside this, I offer training to the people these teams work with. I will then go out and do some health inequalities training and some kind of awareness, and we have a health inequalities workshop that aims to provide a power shift towards communities and people. That staff network is actually becoming self-sustaining. The power is, a lot of the health creation stuff does still work in this staff way. So we are shifting the power towards our colleagues. It's not just a strategic approach. We want people to start really believing in this stuff. Could I have the next slide, please? So also what we've done within our own team, we've heard the word champion a lot today. I'm still not entirely sure that's the right term here, but it is what it is. This is a point of contact for health inequalities. So a third of our workforce are now trained as health inequality champions within the Alliance. And that means that every external, internal meeting they go to, they identify as a health inequality champion. They are writing that in the chat box. They are challenging what they're hearing. They're asking, have you invited the community to become part of this process? We are constantly putting patient and community in the mix. And we empower them. I meet with those people. That's kind of a big part of my role, is to build this army of champions, really. Neil, can I have the next slide, please? And this is one of the ways that the NHS does not know how to work with community as a whole. I'm sure there'll be dispute and chat about that in the box, but that's what I'm seeing. People, they hear about this, they hear about health creation, they hear about health inequalities. It doesn't really affect them. What I want to do is say, yeah, well, yes, it does. It's everybody's role. So when we talk about everybody, And we talk about listening to all of our communities and service users. When we talk about everybody in the NHS, I mean every staff member. So again, this is a support network. I'm working with 260 local organisations and asking them to get involved. And my colleague designed this fantastic triangle because we know those organisations are 100% already out there doing really, really important stuff, and they're parched, they're starved of investment, and their expectation is to do a lot for free. So we've asked them, just start joining us, you know, sign up at the beginning, just become a social media follower, with the aim of moving down this triangle, shifting that power into co-production at the end of the day. And we're not there yet. You know, that would be, I'm 18 months in. One of the good things that happened is the Alliance has recognised that 2 years is a breath in this work, and I've been made permanent in my role. Could I have the next slide, please? So what next? So I think one of the things we put there about community, we do a fantastic investment in our local community. We offer micro grants we give the money to CVSs, and they actually give out the money to projects that are doing something creative. And what we've recognized there is that some of our community organizations are really fantastic at what they do, but they don't have the capacity to deliver on things like we've said. We need to know what outcomes are. We can't just give money, you know, we are as best we can giving money without outcomes. But what we started to do is partner, and actually it's interesting, I'm working with a colleague at Novartis to look at how big organizations can provide capacity building to community organizations. We've got a buddy system where project managers provide support to put some basic governance alongside the CVS, so that the NHS and the community sector are coming together in more ways than one. One of the things I want to say, because I've tried to kind of bring this back in on time, I wrote a few things on my pages, is that names do matter to communities. We said in the chat before, names don't matter, but just to give you an example, for the people that I work with, they have a fear of services. They know what a nurse is, but they don't necessarily know what a healthcare professional is, because it suddenly sounds like something very different. So I just wanted to bring that point across, that we can say this doesn't matter or that doesn't matter, but we're constantly talking about the communities we work with. We come from those communities, we belong. You know, I know where I came from, and I feel very strongly that some of the things we talk about today are way over people's head, but actually the work is already happening. So what I don't want to lose today is what's already going on. It's really, really important that we understand there's some fantastic work going out there, and investment, long-term investment is a key principle to this. And we need to build capacity in our community sector. That may sound really patronizing, but there is a real great way that the NHS can work, and community organizations. And somebody said earlier in the week, if we ignore local business, we're really missing out. Communities are not just our third sector, but all of the investment that goes into our locality. So how I work is, I don't have, it's hard for me because I was always a doer. I'm away from my communities, but what I'm doing, I'm imparting the importance of value in local community throughout NHS managers, through commissioners, through funders, and I'm also supporting people delivering this stuff. So I've got from the bottom, I'm at a sandwich approach, and I'm working through to the middle at the moment. Last code, if Neil could just pull that back up, it might be worth some of you having a look at. It's called the Change One Thing, and this is what I use with all of my staff. So Neil, could we just quickly have that last slide? Sorry, what a nuisance I am. And the reason I wanted to show you this, if you get a chance to scan that on the left, this is kind of a fundamental approach we use across our organisation. Everybody is expected to change one thing about the way they work. Everyone from the admin to the managing director, and we're rolling this out across our region. And it's about taking one thing, deciding at what level you're going to do it, putting your name and a timeline to it, and doing it. And a great example would be putting screens up in our waiting areas, because we have patients who are deaf, who are very anxious. You know, we identify one thing, and we didn't do that alone. We went out and asked local deaf people. So I think I'm going to stop there, But if there was something in terms of call to action that I'd like to say, we need to look at longer term funding, and we need to not ignore, we can talk about community all day, but we need to not ignore that the NHS is part of this. And if their staff aren't ready for health creation, and if they don't understand it, then it will always be seen as a challenge or a negative. It needs to just be built in as expectation and business as usual. Thank you.
Thanks very much, Joe, for that. And I like the closing, words and the challenge. So I'm going to hand over to Lee. Neil, who's going to put us into breakout rooms. I think we're going to have probably about 10 minutes in there.
Yeah, so it's going to be quite short. So we're going to go into some breakout rooms. And actually, just to keep us on time, rather than 15 minutes within the breakout room and 5 minutes feedback, what we'll have is 10 minutes in the break room and 3 or 4 minutes feedback. So I think maybe we should focus actually on 2 questions. Will Core20plus5 deliver for the communities it's intended to support? If you can share your views there. And then really, what do you think of the proposed sort of call to action about actually this needing the long-term funding, and how Core20plus5 can actually be something which can help act as a gateway to embedding health creation and making it practice as normal? There is 5 breakout rooms. I'm going to push the button. You will have to accept to go into the breakout rooms. Each one has a facilitator who will be taking some notes and feeding back. And so we'll see you back in the main meeting room in about 10 to 12 minutes. Okay, let's just pop you into the breakout rooms. So Maren, if you wanted to just go first.
Yes, I think we said that you need to give to do something that the NHS can actually do, and Core20plus5 has done that. But ultimately, this perhaps is about redefining the NHS's purpose and a dual purpose of treating illness and creating health. And then, if that was to happen, this sort of transition that we're asking the NHS to make would be easier. Thank you.
Very much, Maren. Rachel, over to you.
Thanks, Neil. Key themes from our conversation was that the Core20plus5 framework gives an approach starting somewhere, and that feels like a really good way to do it, but that we need to be really individual focused within the conversations and the learning and the qualitative outcomes. In terms of the call to action, a really interesting conversation about early years education, and actually if we start healthy behaviours and healthy conversations with young people, and also at the start of clinical training, how can we start to embed that health creation ways of working and ways of thinking early in people's lives as well as in their training will start to drive some of the shift and the call to action.
Fantastic, great call to action from that group. Lee, over to you.
There needs to be a buy-in from staff, especially senior management, and all staff to embrace those things, and an understanding of the communities that they're dealing with. And finally, they need to be beware of inbuilding inequalities into a system that claims to be challenging them. That was something that came out to watch out for.
Right, thank you very much, Lee. Joe, over to you.
Sorry, Neil, have I got you now? Well, okay, so we had a little bit of discussion in our group around, there was kind of two ideas about clinical priorities or not clinical priorities, whether the focus on the disease means you lose the focus on the community. We felt that there's just perhaps, when we talk about listening to people and communities, we have to actually mean we're listening to the whole of range of diverse of people. But the overall view was that this is far away from what is actually going on for people. There's an awful lot of high level of need at the moment, and perhaps they don't always feel like they join together. In terms of a call for action, we very much like the sort of long-term funding and an awareness for our staff and communities, how they can work together.
Fantastic, thank you very much, Joe. And last but not least, Brian.
Thanks. So people were pretty optimistic about the Core20plus5, felt it was heading in the right direction. but there were two real challenges. Everyone agreed that it takes a long time to do this. And if the funding is short term, it will actually break trust if things are started and then stopped. So this has to be for the long term, or it won't work. And the other big challenge, I think, was if we're just looking at clinical metrics, blood pressure and so on, then probably that will work. But we need other measures of value. How can we measure the degree, for instance, to which we involve communities? And as I put in the chat, there are ways of doing that. So maybe there are other metrics that we should look at.
Thank you very much, Brian. Thank you very much to all the facilitators for feeding back. And I will just hand back to Charles, just slightly over time, but back to Charles just to finish up and round up for the day.
Yeah, thanks, Neil, and thanks, everyone. And apologies, we're slightly over time, so I will not keep you any longer. But it's just to say that it's been a brilliant session, and just a reminder that health creation is a process through which individuals and communities gain a sense of purpose, hope, mastery, and control over their own lives and immediate environment. When this happens, their health and well-being is enhanced. So as we mentioned from this session has been recorded, it will be on the Health Creation Alliance's YouTube page from mid-November. There is an in-person event tomorrow. There will be a write-up as well, and we're encouraging you all to join the Health Creation Alliance for free. Thank you very much. Meron, anything to chip in?
Just to say thank you again to our partners and sponsors. So we're talking National Health Executive, Public Sector Executive, SCW, Novartis, HLM Architects, and lots of others. Help me out.
Solace, and PPL.
And PPL, yes, and apologies if I've missed you, but it's been a great session. Thank you very much.
Thank you,
and certainly, patrons, Lord Adiba, and then Lord Cripps as well. So Lord Victor Adiba will lead, and then Lord Cripps. So you will receive evaluation forms. Please make sure, links to that, and then complete it and send it back, and make sure you spread the word. Massive thanks.
Thank you very much. Thank you.